Welcome back to the deep dive.
Great to be here.
Today we are stepping right into the high-stakes, adrenaline-fueled world of the emergency room.
And it really is high stakes. There's almost nothing like it.
There isn't. We're tackling one of the most complex, terrifying, and frankly fascinating puzzles in all of medicine: traumatic brain injury, or TBI. But before we even start, I have to share something. In prepping for this deep dive, I read a phrase in one of the clinical guidelines that it actually gave me chills.
I have a feeling I know which one you're talking about.
It wasn't a description of gore, not a mortality statistic. It was a rule. It just said, time is brain.
That's the way.
It sounds like, a marketing slogan for a stroke center or something.
Right.
But when you actually dig into the physiology of what happens inside a human skull after, say, a car crash, you realize it's not a slogan.
Not at all.
It is a literal biological countdown.
It is. And it's a countdown that moves faster than almost anything else in medicine. It's a heavy topic, for sure, but it's also one of the areas where clinical logic is at its most elegant, I guess.
Elegant. I like that.
Yeah, we're looking at a stack of clinical protocols and emergency management guides today that really, they strip away the chaos of the ER and reveal the underlying science of how we protect the most important organ in the human body.
And what really grabbed me when I was reading through this source material is this central paradox. You think of a head injury. Let's say someone falls off a ladder or gets T-boned at an intersection, and you assume the doctors are rushing in to fix that damage.
Like to fix the bruise on the brain.
Exactly. You assume they're there to fix the bruised brain, but according to all the research, that is not entirely true.
No, it's not. In fact, thinking that way is a bit of a trap.
They aren't just trying to fix the damage that just happened. They are fighting a ghost.
A ghost. I like that.
They're fighting a second injury that hasn't even happened yet. That completely flipped my perspective on trauma care.
It's the fundamental shift in thinking. It separates a layperson from a trauma specialist. If you understand that paradox, that you are fighting a future enemy, not just a present one, you understand the entire logic of neurotrauma.
So that is our mission today. We are going to decode that logic. We're not just going to list symptoms.
Yeah.
We are going to get inside the mind of the emergency physician. We're going to figure out why they look for specific shapes on a CT scan.
The geometry of bleeds.
Yes, and why the Glasgow Coma Scale is more than just some random numbers, and we are absolutely going to uncover a phenomenon called the lucid interval.
Oh, yeah.
Which sounds like a movie title, but is actually one of the scariest things I've ever read about.
It is the classic silent killer scenario. It really is.
Exactly. So by the end of this, whether you're, prepping for a medical exam or you're just someone who wants to understand how human fragility meets medical science, you are going to walk away with that emergency physician's mindset, ready to scrub in.
Let's do it.
Okay, let's unpack this core concept first, the distinction between the two injuries. The sources are so clear that there is a primary injury and a secondary injury.
Right.
So let's use a hypothetical patient to ground this. Let's call him Alex. Alex is driving, he gets hit, his head strikes the steering wheel. Walk us through the primary injury.
Right. So for Alex, the primary brain injury is the event itself. It's the physics of the crash.
The impact.
The impact. It occurs at the exact millisecond of impact. This is the physical damage to the scalp, the skull bone, or the brain tissue itself caused by that initial blow.
This is the brute force trauma.
Precisely. It's the energy transfer from the steering wheel to his head. And the source material offers us a very hard truth here, something that every doctor just has to accept before they can do their job effectively.
And what's that?
Primary injury cannot be reversed.
That's the hard pill to swallow, isn't it? You can't unring the bell.
You really can't. If the impact is sheared a neuron or crushed a piece of skull or torn a blood vessel, there is no magic wand to undo that mechanical stress in that moment.
It's done.
It's done. Unless you have a time machine, the primary injury is history. Is it the past tense?
But the way this happens isn't always just a bonk on the head. The text mentions acceleration-deceleration injuries. This terrified me because it implies you don't even need to hit your head to get brain damage.
That's absolutely correct. And it's a really important mechanism to understand. Think about the physics.
Okay.
Alex is moving at 60 miles per hour.
Yep.
The car hits a wall and stops instantly. Alex's skull stops instantly, right? Because of the airbag or seatbelt.
Right.
But his brain is floating in cerebrospinal fluid inside the skull. It has momentum.
It keeps going.
It keeps moving at 60 miles per hour until it slams into the inside front of the skull.
That's the first impact, the coup injury.
Yes. And then what happens? It bounces back.
The contra coup.
The contra coup. It bounces back and hits the rear of the skull. But here is the detail that people miss, and the sources really highlight this. The inside of the skull isn't smooth like a helmet.
It's not. I always pictured it as, smooth bone.
No, not at all. The base of the skull, the floor where the brain sits, is full of jagged, bony ridges, sharp shelves, and holes for nerves.
Wow.
It's effectively a cheese grater.
That is a visceral image.
It is. So when the soft gelatin-like brain slides across that during a high-speed stop, the bottom of the frontal and temporal lobes they get shredded.
So it's not just the impact, it's the scraping.
The scraping, the shearing.
Yeah.
It leads to something called diffuse axonal injury, or DAI.
Okay, what is that?
Imagine the brain as a block of jello. If you shake it violently or twist it, you create shearing forces inside the structure itself. You are literally tearing the microscopic connections, the axons, between the neurons.
So it's not one big bleed, it's like cutting the telephone wires to millions of houses all at once.
Exactly.
Yeah.
And that is so much harder to treat because it's everywhere. It's not a single target for a surgeon to fix.
Which pivots us perfectly to the secondary injury. This is where the battle is actually fought. If the primary injury is the fire, what is the secondary injury?
The secondary injury is the smoke damage. It's the water damage from the fire hoses and the structural collapse that happens after the fire starts.
So it's the aftermath.
It's all the damage that occurs later because of how the body reacts to the trauma. The initial hit might disrupt blood flow or cause swelling, and that just sets off this cascade of biological failures.
Right.
The sources list 4 specific enemies here that we're fighting: hypoxia, hypotension, edema, and raised intracranial pressure.
Okay, let's break those down. Hypoxia is lack of oxygen.
Right.
Hypotension is low blood pressure.
Yep.
Edema is swelling. And raised intracranial pressure, or ICP, is, it's pressure building up inside the skull.
It sounds like just a list of symptoms, but it's actually a recipe for absolute disaster. And this brings us to the golden rule of trauma care that the text mentions.
Okay.
The entire medical management strategy, every tube, every drug, every scan, is designed to prevent the secondary injury.
Ah. We accept we can't fix the impact, but we can save the remaining brain tissue from starving or suffocating in the aftermath. That is such a powerful reframing. You're not fixing the bruise, you're ensuring the bruise doesn't kill the rest of the brain.
That's the job.
So let's go back to Alex. He's in the ER. It's chaos. Doctors are shouting. What is step 1?
In any trauma situation, we fall back on the ABCs: airway, breathing, circulation. It's our bedrock.
Oh, okay.
But in head injury, the source emphasizes a very specific modification: airway with cervical spine control.
Why is the spine suddenly the priority when we're talking about a head injury? If his head is bleeding, why are we grabbing his neck?
It's a great question.
Right.
It's because of the mechanism of injury we just discussed. If you hit your head hard enough to damage your brain, like in that car crash, you absolutely hit it hard enough to snap your neck.
The force is that significant.
The force required to crack a skull is easily transferred down the spinal column.
So you have to assume the neck is broken until proven otherwise.
Always. It's the assumption of danger. You immobilize the neck immediately with a rigid collar or manual stabilization. The very last thing you want to do while trying to save the brain is to accidentally paralyze the patient.
By moving their head.
By tilting their head back to check their breathing, you'd be causing an irreversible injury.
That makes perfect sense. Now, once the neck is safe, we look at the airway. And there is a rhyme or a rule in the source text that seems like a clinical mantra.
I know this one.
GCS less than or equal to 8 equals intubate.
Less than 8 intubate. It's one of those rules every medical student memorizes on day 1.
We'll get into the specifics of GCS scoring in a minute, but broadly speaking, if their consciousness level is an 8 or below, they are in a coma. So you put a tube down their throat to breathe for them. My question is, why 8?
Yeah.
Why not 9 or 7? Why not wait and see if he wakes up?
Because waiting is a gamble you will almost certainly lose. At a GCS of 8, a patient is unconscious to the point where they lose their protective reflexes.
Protective reflexes.
Specifically, the gag reflex and the cough reflex.
Ah, so if they need to vomit?
And trauma patients almost always vomit.
Right.
The shock shuts down the stomach, digestion stops, and they purge. If Alex vomits and he's at a GCS of 8, he can't cough it up.
It just goes down the wrong way.
He will inhale that acidic stomach content right into his lungs.
Aspiration.
Aspiration pneumonia. Now his lungs are filled with acid and fluid. Now he can't get oxygen into his blood. Now his brain is hypoxic. We've just directly caused a secondary injury.
So intubation isn't just about breathing for them. It's a preemptive strike to seal off the lungs from the stomach.
Exactly. We take control of the airway to guarantee oxygen gets to the brain. We don't wait for them to stop breathing. We take over before they can fail.
Okay, now moving to C for circulation in the ABCs, the source drops a pearl, a real key nugget of wisdom about blood pressure. Hypotension worsens head injury outcomes significantly.
But that's an understatement. It's catastrophic.
And this is where I need you to explain the physics, because the source mentions something called cerebral perfusion pressure.
This is maybe the most critical concept in neurocritical care. To understand it, we have to look at the Monro-Kelly doctrine.
That sounds like a 19th century political treaty.
It does, doesn't
Yeah.
it? But it's actually simple physics. The skull is a rigid box. Bone doesn't stretch.
Right.
Inside that box, you have three components: brain tissue, blood, and cerebrospinal fluid, or CSF. The doctrine states that the volume inside that box is fixed.
Okay, so it's a packed suitcase. You can't add anything without taking something out.
That's the perfect analogy, exactly. Now, imagine Alex has a bleed inside his skull. He has a hematoma. It's new volume being added to the suitcase.
Something has to give.
Something has to give. The pressure inside the skull, the intracranial pressure, or ICP, starts to rise. It becomes a high-pressure system.
A pressure cooker.
It is a pressure cooker. Now, think about the heart. The heart's job is to pump blood up against gravity and into that high-pressure box.
So it has to fight against that pressure.
To do that, the pressure in the arteries, the blood pressure, has to be higher than the pressure inside the skull.
It's a push war.
It is. We call this the cerebral perfusion pressure, or CPP. The equation is basically mean arterial pressure, which is the push from the heart, minus the intracranial pressure, which is the resistance.
So if the resistance in the skull is high because of swelling and blood?
Then you need a much stronger push from the heart to overcome it and get blood to the brain cells.
And this explains why hypotension, low blood pressure is so deadly.
Exactly. Let's say Alex also has a leg injury and is bleeding out. His systemic blood pressure drops. Now the heart loses the strength to push the door open to the brain.
So the brain is swollen, the resistance is high, and the push from the heart is weak.
And blood flow stops. The brain starves and strokes out. The secondary injury wins.
So wait a minute. This implies that you actually want high blood pressure in a head injury patient.
That is a very common intuitive leap, and it's a great question.
Because I always thought high blood pressure was bad. Wouldn't it, pop the bleed and make it worse?
You have to find a balance, a sweet spot. But generally, in the acute phase, we are much more terrified of low blood pressure than high. A single episode of hypotension can double the mortality rate.
Wow.
We need that driving pressure. We might even give drugs, pressors, to keep the blood pressure up, just to force oxygen through the swelling and into the brain cells.
That really highlights why the ER team works on everything at once. You can't just look at the head.
Nope.
You have to fix the leg bleed to save the brain.
Everything is connected.
Okay, let's unpack that acronym we've been throwing around. GCS, the Glasgow Coma Scale. I feel like we hear this on TV dramas all the time. His GC-ness is dropping. But what are we actually measuring?
The GCS is, at its heart, a communication tool. It's a standardized system to describe the level of consciousness.
Standardized is the key word there.
Absolutely. Before GCS was invented in the 70s, doctors would use these vague terms. One doctor would write in the chart, he's drowsy, another would say he's stuporous.
And those words mean different things to different people.
It's very subjective. GCS puts a number on it. So a paramedic in the ambulance can tell a neurosurgeon at the hospital exactly what is happening with no ambiguity. It has three pillars or components.
Okay.
Eye-opening, verbal response, and motor response.
Okay, walk us through a quick exam on Alex. Eye-opening seems straightforward.
It is. I walk up to the bed. Are his eyes open? Is he looking around? That's a 4. Spontaneous.
Okay.
If they're closed, I say, Alex, open your eyes. If he opens them to my voice, that's a 3. If he doesn't, I apply a pain stimulus, usually a pinch on the trapezius muscle or pressure on a nail bed. If he opens to pain, that's a 2.
And if he does nothing?
That's a 1. No response.
Okay, verbal.
I ask questions. What's your name? What year is it? Where are we? If he gets them right, he's oriented. That's a score of 5.
And if he's a bit off?
If he says, I'm in a library, when he's clearly in the ER, he's confused. That's a score of 4. If he's just shouting random words that don't make sentences, like blue, Thursday, dog, that's inappropriate words. A score of 3.
And
Just groaning or moaning is incomprehensible sounds. A score of 2. And complete silence is a 1.
Okay, and the last one, motor. This is moving arms and legs.
Right. Can he obey a command? Squeeze my fingers, wiggle your toes. That's the highest score, a 6.
And if he can't?
I pinch him again. Does he reach up and try to grab my hand to push me away? That's localizing pain. He knows where the pain is. That's a 5.
Now, here's where the source provided an expert insight that really surprised me. It said that of these 3 I's, voice, motor, the motor response is the most important prognostic indicator.
It is, by far.
I would have thought talking was the most important. If he can talk, he's okay, right?
You'd think so. But speech is very fragile. If you are drunk or high on drugs or just in profound shock, your speech can fall apart.
Right.
But motor response tests the deep, primitive hardware of the brain. It tells us if the brainstem and the motor cortex are still connected and functioning.
And the source mentioned posturing as a very bad sign. What does that actually look like?
This is terrifying to see. If I apply that painful stimulus to Alex, and he doesn't pull away, but instead his arms slowly curl up tight against his chest, wrists flex like a mummy.
That's a very specific pose.
It is. That is decortical posturing. It's a motor score of 3. It means the pathway between the brain's cortex and the spinal cord is damaged. But even worse is decerebrate posturing.
Which is?
The arms extend rigidly straight down by the sides, the palms turn out, the jaw clenches. It's an extensive response. That's a motor score of 2.
And what does that mean?
That indicates damage deep in the brainstem, the reptile brain, the part that keeps you alive. The survival rate for that is very, very low.
Do you have to watch the hands, not just the mouth?
Exactly. And you add these up. The best score is 15. That's us right now. The lowest is 3.
Wait, not 0?
No, you get 3 points just for showing up. 1 point in each category. Even a corpse has a GCS of 3.
Good to know. And the source warns about a trap regarding the GCS. It says, a patient's GCS is not static.
This is the nightmare scenario for a junior doctor, or any clinician really. You assess Alex when he comes in. He gets a GCS of 14. He's a bit confused, but he's talking.
So you think, okay, he's stable.
Right. You walk away to treat a heart attack in the next bay. 30 minutes later, the nurse yells that Alex won't wake up. You run back, and his GCS is down to 6.
He crashed.
He crashed. This is the talk and die phenomenon. If you aren't monitoring the trend, you miss the critical window to intervene.
So it's not the number, it's the change in the number.
Precisely. A drop in GCS of 2 points or more is an immediate neurosurgical emergency. It means the pressure is building, the bleed is getting bigger. It's a scream for help from the brain.
Constant vigilance. Okay, so we've stabilized the airway, we've checked the GCS, now we need to see what is actually going on inside the skull. We enter the detective phase. We need imaging.
And in the acute trauma setting, the tool of choice is the non-contrast CT scan. No question.
Why not an MRI? I always thought MRI was the better scan. It shows more detail, right?
Yeah. MRI is fantastic for detail, especially for soft tissue or old injuries. But in the emergency room, MRI have 2 huge deal-breaking problems.
Okay.
1, it takes a long time. A head CT takes seconds, maybe a minute, tops. An MRI can take 45 minutes to an hour.
And time is brain.
Precisely. If Alex is bleeding out inside his skull, we do not have 45 minutes. It's a death sentence.
And the second problem.
Second, an MRI is a giant magnet, a ridiculously powerful one.
Right.
If Alex has metal shrapnel from the accident, or pacemaker, or even certain tattoos, it's dangerous. And we can't bring in metal crash carts or oxygen tanks if he deteriorates in the scanner. The CT scanner is safer, faster, and crucially, it shows fresh blood and bone fractures incredibly well.
So it's the perfect tool for the job at hand.
It answers the 2 questions we care about most right now. Is the skull broken? And is there blood inside?
Speaking of blood, the source material breaks down the different types of bleeds or hemorrhages. And what's cool in a morbid way is that you can tell them apart just by their shape on the screen. It's like a geometry of bleeds.
It's forensic radiology. It helps us identify not just where the blood is, but what caused it. An artery or a vein.
Let's start with the extradural hematoma, sometimes called epidural.
Right. Extradural means outside the dura. The dura mater is the tough, leather-like membrane that surrounds the brain. It's like a thick sac. So this blood is collecting between the skull bone and the outside of that sac.
And the source says this creates a very specific shape.
Yes. The dura is glued very tightly to the skull of the sutures, those zigzag seams where your skull plates join together. So when blood starts pumping out in that space, it can't cross those seams. It gets trapped in one segment of the skull.
So it pushes inward on the brain.
Right. It balloons inward, creating this biconvex shape. It looks like a lens. or a lemon.
So if you see a lemon shape on the scan, it's an extradural.
Yep.
And the source says this is usually from an artery.
Yes, classically the middle meningeal artery. It runs in a little groove on the inside of the temporal bone, right under your temple, the thinnest part of the skull. If you get hit there with a baseball or a hockey puck, that bone fractures and snaps the artery. And because it's an artery, it's under high pressure. It pumps fast.
Which connects us directly to that movie script phenomenon we teased earlier, the lucid interval. Can you tell us the story of the lucid interval?
This is the classic tragic narrative in trauma medicine. It's every ER doctor's fear. Let's say Alex gets hit in the temple during a game. He gets knocked out for a few seconds. That's the initial concussion.
Okay.
He wakes up. He feels a bit groggy, maybe has a headache, but he is talking. He says, "I'm fine, coach. I just want to go home and sleep it off."
He is lucid.
He is lucid. This is the interval. His family, his coach, they all think he is okay. But inside his skull, that middle meningeal artery is torn. And it is pumping blood fast into that tight space between the skull and the dura.
But why is he awake if he's bleeding into his brain?
Because the brain is compensating. Remember the Monroe-Kelly doctrine? The box is filling up, so the brain squeezes out some cerebrospinal fluid to make room. It buys time.
So it's masking the problem.
It's masking a ticking time bomb. But eventually, the hematoma gets too big. The lemon grows. The compensation fails. There's no more room.
And then what?
The crash. Rapid, catastrophic deterioration. He goes from talking and lucid to unconscious to death in minutes if it's not treated.
That is absolutely terrifying. You think you've escaped the bullet, but the bullet is actually moving in slow motion inside your head.
It's why we never just send someone home immediately after a significant knockout, even if they look fine. We need to rule out that slow, deadly bleed. The lucid interval is a trap.
Okay, so lemon shape equals extradural, which equals artery, which is fast and dangerous. Now, what about the subdural hematoma?
So subdural means under the dura, between that tough dura sac and the brain itself. This is usually a venous bleed.
From veins, not arteries.
Specifically, the bridging veins. These are delicate little veins that travel from the surface of the brain up to the dura to drain blood. Remember that acceleration-deceleration injury?
The brain sliding around inside the skull?
Yes. If the brain slides forward, but the dura stays attached to the skull, those little veins get stretched and snap.
And because they are veins, the pressure is much lower.
It's an ooze, not a high-pressure spray like an artery. And crucially, because the blood is under the dura, it isn't stopped by those skull sutures we talked about.
So it can spread out.
It's free to spread out along the entire curve of the hemisphere.
So instead of a lemon, it makes a
crescent shape.
Mm.
Like a banana or a sliver of the moon.
Lemon is arterial, banana is venous.
Generally, that's a good way to remember it. Subdurals are also very common in the elderly or in alcoholics.
Why them specifically?
As you age or with chronic alcohol use, your brain shrinks a little bit. It atrophies. That pulls the brain away from the dura and stretches those bridging veins tight, like a guitar string.
So they're more vulnerable.
Exactly. So even a minor fall, something that wouldn't hurt you or me, can be enough to snap one of those veins and cause a slow, insidious bleed.
Fascinating. And the third one the source mentioned is the subarachnoid hemorrhage.
Right. This is bleeding into the subarachnoid space, which is where the spinal fluid normally flows.
Mm-hmm.
On the CT scan, you don't see a distinct blob like a lemon or banana.
What do you see?
You see bright white blood filling all the normal dark cracks and grooves of the brain, the sulci and the basal cisterns. It can look like a starburst in the middle of the brain.
And the key symptom here is the pain. All right.
The thunderslap headache. It's a hallmark. Patients describe it as being hit in the back of the head with a shovel. It's instantly the maximum intensity, the worst headache of my life.
So if you hear that phrase, you have to think subarachnoid.
Immediately.
Okay, we've scanned Alex. Let's say he has that lemon, the extradural hematoma. It's growing. We talked about the pressure cooker earlier. What happens if we don't fix it? What is the end game of this process?
The end game is herniation.
We mentioned the box is full.
The box is full, and now it's overflowing. The pressure gets so high that the brain has to go somewhere, but the skull is bone. There's only one major exit, down. Through the hole in the bottom of the skull where the spinal cord comes out, the foramen magnum.
So the brain is literally being squeezed out of the skull into the neck.
Yes, we call this coning, or tonsillar herniation. As the brain is pushed down, it crushes the brainstem against the bone.
And the brainstem controls everything. Breathing, heart rate, consciousness.
Exactly. This is incompatible with life. And just before this final catastrophe happens, the body sends out this desperate, paradoxical distress signal. The source calls it Cushing's triad.
This was the most complex part of the reading for me. The triad consists of three things: bradycardia, hypertension, and irregular respiration.
That's it.
Let's break those down because they seem completely contradictory. First, hypertension, so blood pressure shoots up. Why?
Think about the perfusion pressure again. The pressure in the skull is now massive. The brain is starving of oxygen because blood physically can't get in.
So it panics.
The brainstem screams to the heart, "We are dying, send more pressure, whatever it takes."
So the body dumps adrenaline to spike the blood pressure through the roof.
Massive amounts. The blood pressure can go to 200, 220 systolic. It's a last-ditch survival mechanism to try and force blood into the crushed brain.
Okay, so the high pressure makes sense. But the second sign is bradycardia, a slow heart rate. Why would the heart slow down if the body is in crisis? Usually, panic makes your heart race.
This is the paradox. It's a reflex loop. The heart has sensors in the neck and aorta called baroreceptors. They detect this sudden, massive spike in blood pressure, and they say, "Whoa, this is way too high. We're going to blow a gasket."
So they try to correct it.
They send a powerful signal via the vagus nerve to the heart, telling it to slow way down to compensate for the dangerously high pressure.
So the brain is screaming, "Speed up, high pressure," and the heart sensors are screaming, "Slow down."
And you get this weird, ominous clinical signature. A pounding, sky-high blood pressure, but a slow, thumping heart rate. That is Cushing's triad. It's a sign of a system tearing itself apart.
And the third part, the irregular respiration.
That's the brainstem itself failing. It's being directly crushed, so the finely tuned center that controls breathing becomes chaotic. You get weird patterns like Cheyne-Stokes breathing, where it just stops altogether.
So if a doctor sees Cushing's triad, what does it mean is about to happen?
It means herniation is imminent. Alex is minutes, maybe seconds away from death.
It's the final countdown. So is there anything they can do at that point? Is there a Hail Mary play?
There is. If you see signs of herniation, you have to lower the pressure instantly to buy time for the neurosurgeon to get there. One way we do that is hyperventilation.
Making them breathe faster.
Yes. We take over their breathing with a bag valve mask, we bag them, and we squeeze the air into them faster than normal.
And how does that help? Why does breathing fast lower brain pressure?
It all comes down to CO2, carbon dioxide. When you breathe fast, you blow off CO2.
Okay.
And CO2 is a potent vasodilator in the brain. It makes blood vessels get wider. So if we lower the CO2 level in the blood by hyperventilating, the blood vessels in the brain constrict. They shrink.
And if the vessels shrink, they take up less room in the box.
Exactly. It reduces the total blood volume inside the skull just enough to lower the pressure for a short time. It's a physiological hack. It buys you maybe 30 minutes to get the drill and open the skull.
That is incredible, using breath to shrink the brain.
It's high-stakes physiology right at the bedside.
Before we wrap up, the source listed a few other red flags to watch for. Just quick fire these for us. If a listener is at a kid's soccer game or sees a fall, what are the signs that say this is not just a bump on the head?
Okay, number one, persistent vomiting. As we said, vomiting once might be nerves or shock. If they keep vomiting over and over, that suggests rising pressure irritating the brainstem.
Got it.
Seizures. That's an obvious one, but it means there's electrical irritation of the brain surface from blood or direct injury.
Right. Unequal pupils.
Yes, that is a classic, terrifying sign. The oculomotor nerve, which controls pupil constriction, runs right along the edge of the brainstem.
And when the brain herniates.
As the temporal lobe starts to herniate, push down, it pinches that nerve. And if you pinch it, it stops working.
So the pupil blows wide open on that side.
It dilates and won't shrink even when you shine a bright light in it. We call it blown pupil. It tells you exactly which side of the head the bleed is on.
And one more that sounded strange, raccoon eyes.
Yeah, or Battle's sign, which is bruising behind the ear. This isn't from getting punched in the eye. This is a sign that the base of the skull, the floor of the skull, is fractured.
And the blood is tracking forward.
The blood is seeping from the fracture into the soft tissue around the eyes. It means massive force was involved.
That's an immediate ER transport.
No question.
So let's just recap this entire journey. We started with the impact, the primary injury, which, as you said, we can't fix.
Right. The damage is done at that point.
But we learned that the real war is against the secondary injury, that ghost. The hypoxia, the hypotension, the swelling, the pressure. And the ER protocol, the ABCs, the C-spine collar, the intubation rule of GCS less than 8, is all about winning that war.
Prevention is the only cure we have.
We decoded the GCS eyes, voice, and especially movement being the key. We learned that a lemon-shaped bleed is arterial and a banana-shaped bleed is venous.
And we learned to fear the lucid interval.
Absolutely. And finally, we saw the body's last-ditch effort to survive in Cushing's triad, the high pressure and the slow heart rate telling you the end is near.
It's a lot of information, I know, but the core philosophy remains so simple. Time is brain. Every single minute of low blood pressure, every minute of low oxygen kills millions of neurons. Early, aggressive management saves who that person is.
That's the emergency physician's mindset. The thing that really sticks with me, the provocative thought, is the fragility of it all. That a
Yeah.
normal CT scan doesn't always mean you're okay, it doesn't rule out a concussion or DAI, and that a walking, talking patient might be the one in the most danger of all during that lucid interval.
It teaches you to look deeper, to never be falsely reassured.
It really does. It challenges us to look beyond the surface, literally and metaphorically. Just because someone looks okay on the outside doesn't mean the storm isn't gathering on the inside.
The valuable lesson for medicine.
Yeah.
And probably for life, too.
Absolutely. Thank you all for listening to this deep dive into the logic of trauma medicine. Hopefully you never have to use this info, but now you know what's happening when those doors swing open. We'll catch you on the next one.
Stay safe.